Welcome to the Masterclass on Neonatal PICC line insertion. This Masterclass is aimed at doctors specialising in paediatrics and neonatology and advanced neonatal nurse practitioners. I am Felicity Brocker, a neonatal consultant working in the UK. I've chosen the subject of neonatal PICC lines as these peripherally inserted central catheter lines form an integral part of the management of both sick and premature babies on the neonatal unit. They enable us to provide nutrition and hyperosmolar drugs to these babies. The subject matter is really important, as inserting these lines is not without complication. Complications can occur and include central line associated bloodstream infections or CLABSIs. The lines can become blocked. The lines can extravasate. If extravasation occurs in the heart, you can get a cardiac tamponade, which if unrecognized is fatal. As with everything in medicine, patient safety is of utmost importance. It is therefore really important to ensure that all staff who are placed in these lines are appropriately trained to do so in order to minimize complications. There's a lot of information available on the subject matter. However, for those of us working in the UK, it is important to be aware that the British Association of Perinatal Medicine, or BAPM, has published a framework for practice on the use of central venous catheters in neonates in 2015. This was revised in 2018. The BAPM framework states that we need to always inform parents that when we are inserting these lines, units inserting PICC lines should have a care bundle in place. You need to be formally trained if you're going to insert a PICC line. The most appropriate person should always place the line. You need to be familiar with the equipment on your own neonatal unit. There needs to be a standardized approach to calculate the length of insertion. If you feel resistance on insertion, it is likely that the line is malpositioned. Always ensure that you can freely aspirate the line. All line tips should lie outside the cardiac shadow. So for upper PICC lines, this means they should ideally lie within the superior vena cava, and lower PICC lines ideally in the inferior vena cava above L4 and L5. If the line is manipulated, a repeat X-ray needs to be done to confirm the position. There needs to be appropriate fixation of the line to the skin to minimize skin injury. Always clearly document when you have placed a line. A neonatal or pediatric consultant or radiologist needs to confirm the line position within 24 hours in writing. These lines need to be reviewed daily as to whether they are still necessary. There needs to be ongoing care and documentation of the line and the line site. If a patient with a PICC line deteriorates, always think, could this be the PICC line? Before inserting a line, some preparation needs to take place. You need to choose a vein, choose the PICC line, prepare your equipment, and the procedure itself. Always use a good light source to help you choose a vein that you will use. In neonates, you can use veins in both the upper limbs and the lower limbs, and sometimes, if necessary, the scalp. You need to measure the insertion distance. In the upper limb, this is from the point of insertion to the sternal notch, and in the lower limb from the point of insertion to the Xiphus sternum. You then need to decide which PICC line is the most appropriate line to use, based both on the size of the baby and the vein you have chosen. You really need to be familiar with the lines that you have available on your own neonatal unit. These are examples of some of the PICC lines that are available in the UK. The PICCs are smaller 1 French lines and are designed for use in babies weighing less than 1,000 grams. And the neutral lines are 2 French lines designed for use in larger babies. For the sake of this demonstration, we will be using the PICC with stylet. You then need to prepare your equipment. You will need a trolley to lay your equipment on, detergent wipes for surface cleaning of both the trolley and the incubator. You will need a good light source, sterile gown, 2 pairs of sterile gloves, a PICC placement kit including the chosen line, a split needle or appropriate cannula, a bionector, a non-toothed artery forceps, 0.9% sodium chloride to flush the line, sterile drapes, sterile gauze, steri-strips, and a transparent sterile dressing. In this video you can see that we are using the PICC with stylet. we will be using a 24 gauge yellow cannula to feed the line through. However, if the vein that you have chosen is large enough, you can use a splittable needle supplied with a PICC. It is really important that the entire catheter is flushed through with normal saline right to the tip. The actual procedure itself. We have chosen to use a greater saphenous vein on the right lower limb. With the help of your assistant, you will pass the foot through a sterile drape, holding the foot with a piece of sterile gauze. You're then able to clean the foot as well as the entire exposed area with your chosen cleaning solution. Once you have done this, you will place the foot through another sterile drape and remove your first pair of gloves. Using a piece of gauze, you can form a tourniquet above the point of entry. The vein can then be accessed with a cannula. Once you have flashback, advance the cannula and remove the needle. You're then able to advance the catheter to the previously measured insertion distance using the non-toothed forceps. Sometimes, as in this case, it may be necessary to insert the entire catheter into the vein. If this is the case, it is often easier to secure the catheter to the cannula using steri strips to prevent kinking of the PICC line at that site. The stylet can then be removed and disposed of. All PICC lines need to be aspirated to confirm that they are in a large vein. They must also flush easily. The cannula can then be removed, ensuring that hemostasis is achieved at all times. Once hemostasis has been achieved, a steri strip can be placed at the point of insertion. This will help anchor the line and prevent it moving. You can then place a transparent sterile dressing over the area and the line, ensuring that this is not circumferential. Once the line has been inserted, the line needs to be x-rayed to ensure that it is in the correct position. If you're using a 28 gauge PICC line, such as the Premier Cath that we have used, I would recommend that you use contrast such as OmniPEG to aid visualization of the line. The position of the arm largely depends on which vein you have chosen to use. For the basilic vein, the shoulder should be in adduction and the elbow in flexion. For the axillary vein, the shoulder should be in adduction, and for the cephalic vein, the shoulder should be in abduction and the elbow in flexion. The reason for these positions is that a study by Nadru and colleagues has shown that this will move the line towards the heart and will thus ensure that the final position is safe. For upper limb lines, the tip should lie in the superior vena cava above the right atrium. In the top two images, you can see that the line is perfectly placed. In the lower three images, the lines are all incorrectly placed. In the first image, the line has taken an incorrect path into the neck vessels. In the second image, the line is too short. And in the last image, the line is in too far and in the right atrium. All these lines will need to be repositioned, and once done, it is really important that a repeat X-ray is done to confirm the final tip position. In the lower limb, the tip should lie in the inferior vena cava just below the right atrium. On X-ray, this will correlate to position just below the cardiac shadow at the level of the diaphragm. In the top two images, you can see that both lines are perfectly placed. In the lower two images, the first line has advanced too far and is in the heart. This will need to be withdrawn, and a repeat X-ray will need to be done to confirm the line position again. In the last image, the line has likely ended up in one of the small lumbar veins. This is a dangerous position as there's a high risk of extravasation in this area, and the line will need to be removed. For all saphenous PICC lines, the line should go into the left iliac vein, cross the midline at L4, L5, and then run to the right side of the vertebral column in the inferior vena cava. There should be no tortuosity in the path of the PICC line. Once you've inserted the line, it's important to document this in the patient notes. You can use insertion record stickers such as this one from BAPM. In summary, PICC lines are an essential part of neonatal care. If you're going to place them though, you need to make sure that you're appropriately trained to do so. Should you have any questions, please do contact me on my email address below. I really hope that you've enjoyed this masterclass and that going forward you will feel more confident in placing your PICC lines. Good luck.